Thank you very much. I'm supposed to talk about the worst case, and then afterward, I have to talk about the best case. So in between that, I present this case. This is, you can say this is the worst, you can say this is the best. Good from far, far from good. So this clinical history, 88 years old male, present with acute MI. In 2014, he got a 2 stent in LAD and 1 stent in circumflex. He had a hypertension, smoker, and dyslipidemia, LVF 46%, anterior hypokinesia, normal LV, normal renal function, syntax score 20, AUR score 0.99. Look at this ECG that showed the ST elevation in our AVR and also the anterior wall. This is the angio, looks okay from the right side, it's not a very significant disease. But at the left side, there is haziness at the left main, distal left main. So the flow to the LAD was diminished. At the time, we did IFUS after pre-dilatations to LAD. You can appreciate here the preview standard segment, and then coming to the left main. So yes, that's what you can appreciate here. There is an eruptive calcified nodule from the left main to at the left main. And then IFUS ran to circumflex, quite difficult. Get the catheter got difficulty, but we found there is a calcified, eruptive calcified nodule. So this is the left main. And then we decided to rotablate using 1.75, went to the circumflex route because diminished flow at the LAD, and there is a stent there just so you can appreciate here the burr go. And then afterward, we paradilate using a Scoreflex balloon to LAD circumflex. And then, as usual, we decided to use a decay crash strategy. Of course, first we put the stent 3O DES to, from circumflex to LAD, and then flaring the OCL circumflex with high pressures, and then crash using the 3O balloon. Please pay attention. That is, we crush it with a 3O non-compliant balloon. And then afterward, we did a first kissing. And then putting the LED 3.5, 28, and then pot using 4.5 millimeter NCD. And then the second kissing using 3O balloon at circumflex left main, and then 3.5 balloon to LAD. And we also optimize the mid-proximal part of LAD using the balloon, 4O balloon. And then we do the report. Sorry. Sorry. So the result is very beautiful. Looks well expanded stent. And this is the from the LAD post IFUS. The stent expands well. And then there's our circumflex as well. You can see, appreciate here, coming stent to. So let's focus to the IFUS from circumflex. So if we have a time, we can interactive what kind of the IFUS finding, but because of in the interest of time, the ECG looks better, and the echo looks okay. Preserve LVEF. But what actually I miss when I relook left main IFUS, left circumflex from IFUS, look at the ostial part of the IFUS, of the circumflex, sorry. Yeah, that's why I cannot stop it. Yeah, that's what I got it. The stent crash, this is the healthy, it's not stented wall. This is stented wall, but there is two stent layer here. So what actually happened is the stent, is the proximal L6 stent being pushed toward the lateral wall. That's what we should do with such situations. How did it happen? It happened because of distal abdominal side. When we are using wire to distal, actually should be at the decay crash, non-distal, rewire to non-distal part. But sometimes it's quite difficult to find out whether this is non-distal part. And the wire turned out to be, went to the abdominal side. And then we crush these things. So how to prevent it? The patient is very good until 7 months, and now we have no any complaint, any clinical situation. That's very nice. But I would like to show to you that what I miss actually when did IFUS. This is another case that bifurcations. Then we did IFUS, and then afterward we putting the stent here, and this is the balloon, LF min LAD, completely crushed to circumflex. As you recall, we used 3O balloon when crushed the previous one. And then we rewire circumflex and identify whether the wire went to abdominal side or not. So we perform IFUS, and then to identify, because if it happened, fortunately at the previous time, the previous case, the vessel or the ostial part is very big, so there is no ISR that make a clinical problem. So look at this. Sorry, I cannot move it. Okay, because of interest of time, you can use IFUS actually to make sure. This is longitudinal, this is the wire. So this is the distal part, and then coming the wire. So this is really the wire, not went to abdominal part. So based on this, we optimal circumflex stenting. This is the final result. And look at the circumflex left main pullback. The ostial part of the circumflex covered by a stent. So the decay crush entails multiple steps and can be challenging to perform. Incomplete crush and abdominal distal rewiring inside branch are the two important pitfalls in decay crush. Improving PCI strategy by intracoronary imaging may come from correct identifications and appropriate reacting to the finding and not merely obtaining image. Don't was a good mistake. Learn from it. Thank you very much.